We'll be discussing surgical anatomy of the rectum and colon. Now, it is very important in a successful outcome of managing colonic or rectal cancer, the anatomy. Now, by the end of this lecture, you should be able to tell, am I doing a type 1 resection when I do a right hemicolectomy or a left hemicolectomy? Am I doing a type 2 resection or am I doing a type 3 resection? When you are doing type 2 or type 3, it is not acceptable. You also ask yourself by the end of this lecture, anytime I do a right hemicolectomy, do I display my specimen to inspect where is the right colic artery? Where is the middle colic artery? Where are the principal lymph nodes? Where are the pericolic or the epicolic group of lymph nodes? If you are not doing this, you are not doing oncologic resection. Now, the essence of this anatomy is to pinpoint those silent points. When you are doing a left hemicolectomy, are you doing your anastomosis within the last 10 centimeters of the rectal? If you want to do maybe a colorectal anastom after resecting the sigmoid, you shouldn't do any anastomosis within 10 centimeters of the rectal stump because of the pseudocritical angle. At the splenic flexion, the critical point of Griffith, you have to avoid all these places because they are precarious. So these are some of the important areas you need to pay attention to during your surgery. So that is the essence of this presentation. Okay, so how do we? Okay. Is it? Okay. Okay. Now, let us look at the gross anatomy. If you remember, the colon is averagely, it varies from patient to patient, but averagely is 1.5 meters. If you remember the length of your colonoscope, if you are doing colonoscopy, which every general surgeon must be able to do that. If you are not doing colonoscopy, you have to go for training for colonoscopy because your training as a general surgeon will be incomplete. Now, the length of that scope is like 160 cm. Why? The average length of the colon is considered when making that scope. You understand? That is the length, the average length of the colon. But of course, it varies from subject to subject. Okay? So, these are the subdivisions which we all know and their respective lengths. The cecum, ascending colon up to 8 inches, the hepatic flexure, and all these are various aspects. Now, there are 3 important characteristics of the colon which are absent in the rectum. Anytime you remember these 3 important characteristics of the colon, they are absent in the rectum. Number 1, tinea coli. Okay. Number 2, appendices epiploicae. And number 3, haustral markings, haustrations. These are 3 characteristics of the colon and are absent in the rectum. Of course, we know tinea coli is a longitudinal muscle. There are 3 that converge at the base of the appendix. It's a characteristics of the colon. Appendices epiploicae. is more numerous in the sigmoid colon than the transverse colon. It's also absent in the rectum. That is the second feature of the colon. Thirdly, the hostrations. Because of that tinea coli now, which is actually shorter than the length of the colon. So it now gives bulging folds. The actual length of the colon should be longer than the tinea coli. But because of that tinea coli, it's giving it folds, giving haustral markings. Now, these three features are absent in the rectum. Now, we should know transverse and sigmoid colon are peritonized, thus having mesentery, but the ascending and descending colon adhere directly to the posterior abdominal wall, having only their anterior and lateral segments peritonized. The rectum is extraperitoneal on its posterior aspects in its upper one-third, posteriorly and laterally in its middle, and completely extraperitoneal in the distal one-third as it sinks below the pelvic peritoneum. So you should know for the rectum is only the upper one-third, is only the posterior part is extraperitoneal. The anterior and the lateral part are covered with peritoneum. The middle one-third is only the anterior part that is covered by peritoneum, while the distal third is completely extraperitoneal. Now, what is the importance of the relation of the colon? When you are doing surgery, you can just, as a general surgeon, just sweep. You know there is nothing there because you know the relation. You can just sweep and take some tissues. But there are some areas that you wouldn't do that. Of course, when you know the relationship, there are some you can see, of course, you know you meet them when doing a right hemicolectomy. The ascending colon posteriorly is crossed. It crosses the right iliac crest, ascend in front of the quadratus lumborum. So it's a muscle, you have no problem with that. Psoas muscle, no problem with that. Right ureter, right gonadal vessels. To the undersurface of the right lobe of the liver, of course, where you have the hepatocholic ligament, when you are trying to mobilize that condensed peritoneum, is hepatocholic ligament, you have to cut it to mobilize that part off. It makes a right angle bend in front of the lower pole of the right kidney, the hepatic flexure, and becomes transverse colon. Now, these are the posterior relations of the transverse colon and the ascending colon. Notably, you should know the right ureters and the right gonadal vessels that are injured in right hemicolectomy. And of course, if you start mobilizing the transverse colon, you just see the bulb of the what do you call it? The second part of the duodenum there. So those are the three important structures that are injured in right hemicolectomy. The right ureter, the right gonadal vessels, and the second part of the duodenum. And for the transverse colon now, of course, superiorly, you can see the liver from the image. From the diagram, you can see the liver, gallbladder, and the stomach. Of course, sometimes you have colonic tumors, transverse colonic tumors that fistulate because the transverse colon forms part of the stomach bed. There are 5 structures that form stomach bed. Transverse colon is there in advanced malignancy. It can fistulate, and you see patient vomiting feces in gastric tumors. When they fistulate, they can vomit feces. Yes, There's gastrocolic fistula. So sometimes, and this may cause problem when you have advanced gastric tumor, you think it's a colonic tumor when it is infiltrating. Posteriorly, the front of the right kidney, second part of the duodenum, and head of the pancreas, it makes an acute angle at the splenic flexure and becomes the descending colon. Now, the descending colon descends in front of the left kidney, left ureter, left gonadal vessels, and the left iliac crest, where it becomes sigmoid colon at the pelvic brim. Now, the sigmoid colon, the relations bladder anteriorly and coils of the ileum. So on the descending colon, of course, the left ureter and the gonadal vessels. The blood supply to the colon. Okay, the large bowel receives blood from both superior and inferior mesenteric arteries. Of course, we know the anastomosis of both branches form the marginal artery of Drummond, from which shorter straight vessels arise to supply the large intestine. And of course, because the blood supply in some certain areas of the colon are precarious, there's chance for anastomosis here. This is a watershed area. This is also a watershed area, which we will see shortly. Now, branches from the superior mesenteric artery, ileocolic artery, supplying terminal ileum, cecum, and commencement of the ascending colon. It gives off an appendicular branch to the appendix. Right colic artery supplying the ascending colon. Middle colic artery supplying transverse colon. Of course, we know all these form arterial arcades and forming the marginal artery of Drummond. Left colic. Now for the inferior mesenteric artery, the left colic supplying descending colon, sigmoid branch, the sigmoidal branches supplying sigmoid colon, and the superior rectal or hemorrhoidal supplying the rectum. The veins follows the artery. You should know that the superior mesenteric artery arises from the abdominal aorta at L1, while the IMA is given off at L3. Now, before we go into the lymphatic drainage, which is one important aspect of this anatomy, if you look at this blood supply, there are some areas that are danger areas. Now, the sigmoidal arteries vary in number. It could be 2 to 4. And they are end arteries. The first sigmoidal artery will anastomose with the descending branch of the left colic. And the last sigmoidal artery at the rectosigmoid junction will anastomose with the ascending branch of the superior rectal artery. That area is called the danger area or the critical point of Sudeck because it's precarious. So any supply, if you are doing anastomosis, always avoid the first 7 to 10 cm from the rectosigmoid junction because that area is precarious. Go close as possible to the rectum. Don't just say, okay, you are doing a rectal surgery. You say, okay, I have sufficient tissue here. Let me just bring my bowel and do anastomosis. You are risking it because it's precarious. Here also, around the splenic flexure, the critical point of Griffith is also a watershed area where you have anastomosis of the ascending branch of the left colic and the left branch of the middle colic. It's also a precarious area for obvious reason. One, there are straight arteries, end arteries, poor collaterals, and they easily get thrombosed. Okay, so those are important points. Sometimes you can, rarely you can have anastomosis between the superior mesenteric artery and the inferior mesenteric artery. Rarely is a collateral arc of Roland. It's very rare. It's not something you rely on and just ligate one of them and say, okay, let me rely on arc of Roland. No, it's not commonly. Okay, now the lymphatic drainage. You know, the lymphatic drainage, they follow the distribution of these arteries in a pattern. Epicolic around the tinea cola, the wall of the vessel, paracolic on the paracolic gutter. They now follow, drain into the intermediate group. Those intermediate groups are in the branches of this main arterial supply, going to the principal groups that are at the main arteries. That is the lymph nodes along the superior mesenteric artery, the inferior mesenteric artery. They now finally drain into the para-aortic group of lymph nodes or into the cisternal chyli. Is it thoracic duct? Cisternal chyli. Okay, so there is a pattern, the epicolic and paracolic draining into the intermediate group, the branches of those main artery, and then into the principal group along the main trunks, then the para-aortic group of lymph nodes. That is the pattern. So it means, in essence, if you are doing surgery and you don't bother in taking this fascia along, taking this mesentery along the vessels and the lymph nodes, you are not doing what you are supposed to do. And there is high risk of recurrence. So let's see what we are talking about. Okay, sorry. Before, I would have loved to show that. Before we talk about the rectum. Now look at this. Type of colectomy specimen. There are 3 types. Okay. There are 3 types of colectomy specimen. Number 1, complete resection with intact mesentery. When resecting, you follow the mesentery carefully along the blood vessel up to the proximal point of ligation. You are seeing the aorta. You are doing oncologic dissection. Don't just bring out a lumen. This is the ascending colon. You are taking where you have left a lot of lymph nodes. No, you have to follow. You have to be patient in oncologic dissection. You have to take it up to the branches where they originate and see it. You are not ligating flush because you have risk of slippage. Just give a little, maybe 2 cm, but make sure if there's any node there, you take it along. You can double ligate, but you have to see the major vessels. If you are not seeing those major vessels, you are not doing the right thing. Type 1 is complete resection with intact mesentery. And this, you must have to inspect your specimen. Type 2, complete resection without intact mesentery. You see half, you left half inside. Or incomplete resection. This is the tumor. As if you are doing a benign resection. It's not acceptable. Now look at this specimen. You can see this is the sickle, okay, small ball. The mesentery is intact, though it was not spread to label. Oh, sorry, this is not very clear. Yes, but you can see the bowel is there, the mesentery is there intact. And of course, you have to display the blood vessels. See all the branches. Now look at this. Is this acceptable? No. In fact, the mesentery is inside. So this patient has a high risk of recurrence because you left a lot of nodes. You can see the chain of transmission of lymphatics, epicolic, paracolic, intermediate, principal, aortic, and all that. You left all those things, but you are very happy that, of course, you have a terminal ileum there, maybe 10 cm, 10 to 15. You are demonstrating cecum ascending colon, but this should be linked. There shouldn't be this wide gap here. So please, anytime we are doing surgeries for malignancy, we must ensure oncologic resection. Let's see another one, whether it's adequate. This one is even skeletonized completely. Okay, it's completely skeletonized. So we don't know what he did. Maybe it's for benign lesion, but it's completely skeletonized. Okay. Now let us find a habit of doing something like this, labeling all our specimens. This is also completely skeletonized. Okay, so this is not acceptable for a malignant dissection. Okay, I don't know if, can we still proceed with the rectum? Okay. Okay, the rectum now. This is just showing us the position of the rectum and its extent, commencing from S3, and the shape of the rectum. It's 12 cm, 12 to 15. You know, it varies in length. It starts in front of the third sacral segment and ends at the level of the apex of the prostate, or lower 1/4 of the vagina, where it leads into the anal canal. The course of the rectum is marked by two flexures. The sacral flexure, which is what anterior-posterior curve, okay, with concavity anteriorly. If you look at this, follows the curve of the sacrum. Yeah. Then you have the anorectal flexure. The anorectal flexure, which is anterior-posterior curve with convexity anteriorly. This flexure is formed by a tone of the pulporectalis muscle and contribute significantly to fecal continence. You know, we said the rectum doesn't have hostration, but it has folds. It has valves. Okay, there are 3 valves. It has lateral inflections, superior, intermediate, and inferior, giving it a lazy E shape. Okay, a lazy E shape. These valves of Houston are bulging into the lumen, okay, to increase capacity. And below here, you have the ampulla. You remember, for storage. If you have distension of this wall, accumulation of feces, it will stimulate defecation reflex. If there's a mass here that keeps on growing, it will be stimulating tenesmus. Persistent urge to defecate that is non-productive, because there's a mass effect there. The guy tries to bring out stool, but nothing comes out. Maybe just some mucus will just come out. These inflections are due to valve of Hustings, which are formed by transverse folds of the internal rectal walls, projecting left, right, left. It means there are two folds, two left and one right, giving this lazy E shape. The final segment of the rectum, the ampulla, relaxes to accommodate and temporarily store feces until defecation occurs. It continues with anal canal, which passes through the pelvic floor to end as the anus. Okay, so we've talked about the peritoneal covering. So I'll just keep this. Now, the relationship of, what is going on? Relationship of the rectum. Posteriorly, the sacrum coccyx, middle sacral artery, separated by Waldeus fascia. Anteriorly, upper two-third covered by peritoneum, coils of intestine in the rectal vesical pouch or pouch of Douglas in female, lower one-third related to the prostate, bladder base, seminal vesicles in male, vaginum in female. That's why if you are doing lower rectal procedure, you should be putting your finger in it, especially if you are using stapler. There's this procedure we don't commonly do. You see this hemorrhoid stapler, in a frail patient, you can actually resect the rectum with it. If you have a very good stapler, you can do a transanal, transanal, rectal resection. Use that stapler to resect the anterior. You have to use two staplers. When you are resecting the anterior, put your hands into the vaginum because of that distal relation. If not, you create a fistula. So you resect the posterior, you see the you resect the anterior, you see the posterior bulging out. Then you now use the stapler and resect the posterior. You are not doing circumferential this time around. You need a tongue depressor and all that. It's very expensive procedure, but very effective. Why is it expensive? You have two staplers. You do it for a patient, 2 days, patient is discharged without any problem. So you have to know this distal relation of the vagina, okay? Now the blood supply, we talked about it, that you have the superior, middle, and inferior rectal arteries. 5 arteries in all. But you should know it's only in 25% you have middle rectal arteries. Up to 70% is absent. Even that 25, when they are present, they are either small or rudimentary. It's an inconsistent artery, the middle rectal. But the superior rectal is there, which is a continuation of the inferior mesenteric. It now divides, as you can see, into right and left. Okay, the middle rectal artery is coming from the internal iliac, the anterior branch of the internal iliac, but it's not consistent. Then you have the inferior rectal artery, which is coming from where? Internal pudendal, which is also a branch of the internal iliac artery. So this is just a demonstration of the superior rectal artery. Of course, most of the time they will tell you the veins will follow the artery. Of course, you don't need to waste time there. And you know the significance of these veins in portal hypertension. Okay. Lymphatic drainage, pararectal nodes, then the superior rectal, inferior mesenteric. Okay. Lateral and medial sacral nodes with the middle rectal artery and internal nodes. Okay, we've already talked about this because they are all related to the, but anal canal is not part of the, because they have a different embryonic origin. So we might not we won't go into this, but you have, it's just it's something, we all know these things. It's just to refresh and highlight some important points. But you all have the slides and the recording. Thank you very much.